Welcome, everyone, to this episode of Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with my special co-host, Dr. Lee Merritt. We're sponsored by the Freedom Hub, which is at your-mp.com, and we're definitely trying to be the disruptor's intersection, and you'll see tonight is going to be no exception to that. Our biggest concern is that there's a lot of stuff going on out there, and we keep trying to expose this every week. And it used to be you and your doctor, and there's all this parade of people in between, which is really disrupting it. And all they can do is make it more complicated. And then, after a while, when people started to tell me, hey, my health insurance premium is bigger than my mortgage, now they're starting to try to figure out how to get a return on their investment. And that's pretty scary. And then, of course, as we're going to disclose yet again, in many ways, there's a lot of information. And how do you sift through it to figure out which is right or wrong? And then it's starting to look grim. And so we're very fearful of where things could potentially go. So we're going to see where we're at for tonight. Now, if you come over to the website at your-mp.com, you'll see there's a lot of great drop downs, but we're focused on the webinars. So under the home tab, you'll see it says webinars, and then it says continuing the conversation. I want to start with that one for a moment, because this is where you connect with the guests after today. So when they have something really exciting for you and you want to start to engage with that person, here's where you come over to make that happen. So let's take a look, though, where we are under our webinars for today. So if we scroll down on that particular page, you'll see that we're here at our one with David. But what I want to do firsthand is I'd like to introduce our special guest. She's our co-host tonight. Now, this is Dr. Lee Merritt, and a lot of you may be familiar with her, and she's now known as the medical rebel. And she was a regular orthopedic and spinal surgeon, but then things started to come unglued with this whole pandemic, and that kind of changed her whole nature. So you're going to want to kind of follow up on her situation and see what she's up to. And she's been a guest as well, so you can certainly connect with her on the continuing the conversation area. And she's going to do a great job here of introducing and co-hosting with me with our special guest tonight, which is David Levien. So Lee, if you would.
Oh, thank you. Dr. Levien is a fellow surgeon. He received his BA from Johns Hopkins University and his MD cum laude from the Georgetown University School of Medicine. He was trained at the University of Massachusetts and served the colorectal surgery fellowship at the Ferguson Clinic. So he's board certified in general surgery and colon and rectal surgery. He's held additional qualifications in critical care. And he's also a physician management expert. He's practiced surgery for 33 years. He was chairman of surgery, and he was a program director for a residency. He served as the member of the board of directors of the College of Physicians of Philadelphia, the Philadelphia County Medical Society. He's been on the board of directors of Meals on Wheels and Senior Outreach Services in Walnut Creek, and is on the board of directors of the Chamber of Commerce of Pleasant Hill, many other things. So he's published 3 books of surgery and multiple papers in peer-reviewed journals, as a fellow of the American College of Physicians Executives, and is a certified through them. So thank you very much for joining us, and welcome, Dr. Levien.
Well, thank you very much, Dr. Merritt, for that very kind introduction. I think I'll share my screen for a moment and we'll get started. And I want to thank Jeff Cantor for making this opportunity to talk available. So let me just get rid of this control bar. Okay, can everybody see my screen?
Yes, I can.
Okay, great. Well, again, I think Jeff had asked me to share a little bit about our organization, the American College of Healthcare Trustees. And so I'm going to go over a little bit of the history, some of the things we've done, and then I'm going to talk about the problem at hand and disrupting healthcare delivery. And then we'll talk about an event we're having on October 29th. Let's see here. Okay, so we were founded in 2013. We're a social enterprise, and our mission is to improve the quality of governance, leadership, and decision-making in healthcare. And we're a for-profit C corporation. We have an outward frontier and an inward frontier. And here's our outward frontier. And this is what I've been involved in for all these years, the critically ill, multiple trauma patient. This patient has a halo, so it's more in Dr. Merritt's domain. But the sick patient, the solution shop is pretty much what I've been involved with. But I do have an interest in the health and well-being of the general population. We also have an inner frontier, and our goal is to advance the endeavors of our fellows and our board members. Here you see a group of people gathered towards the end of one of our great conferences in Pebble Beach. We had some of the most visionary people in healthcare speaking at this conference. We ended the lectures at 2 o'clock each day so people could walk on the beach and be mindful. And then we reassembled for dinner and networking by the fireplace. So people that had never met each other before are now close and working together, and the cross-pollination of ideas and transcending of silos is really what we aim for. Asilomar is a beautiful setting. It's a refuge by the sea. And it's very interesting because this was a place when we all know that innovation comes into being well before the ethics and legality of it is worked out. And Asilomar was where scientists from Stanford, University of California at San Francisco, got together with journalists and attorneys to work out the ethics and legality behind gene splicing and how the research would be conducted. And we had our conference at Asilomar as well, although I certainly make no claim that it had the impact that the Asilomar conference on gene splicing had. But I was very happy to note that they had a conference after ours on the to work out the ground rules, the ethical ground rules for the deployment of artificial intelligence in healthcare. And that's something that's part of our curriculum, health tech, and that's the subject of a different talk. So we very much believe in the quadruple aim, and I'm sure you've heard that talked about many times, but it's providing healthcare that's high quality and safe. It's healthcare that's patient-centered, and it's financially sustainable. And that's the triple aim as espoused by the AHRQ. And we argue for the quadruple aim, that we argue that it should also provide a good quality of life for the healthcare workers, the doctors, the nurses, the other associates, because happy people are engaged people, and they are more likely to give the best care. Now, this is a business model adapted by Christensen and Wong, and I think it's a very useful construct for people to get a handle on. So they talk about solution shops, value-added shops, and facilitated user networks. Now, my entire 33 years, really 40 years when you think about it, has been in a solution shop. And that's where we address unstructured, complicated problems. It relies on heavily educated workers Examples of this would be law firms, various consultants, physicians' practices, and hospitals. And the service is unique for each customer. It's highly intuitive, and the prices are high. So then Christensen and Wang talk about value-added processes. And essentially, there's an input and a value-added and an output. And this is repetitive, there's less variation, and it's much less expensive. Examples of this are in retailing, auto manufacturing, the dock-in-the-box, the retail clinics. And this can often be given by mid-level practitioners, nurse practitioners, and physician's assistants under the supervision of a physician. And it's less dependent on intuition and requires less education. And it's usually done by practice parameters and various paradigms. Then the other very interesting and useful construct is facilitated user networks. And we all know that physicians are under huge pressure. They really, the private practitioner can't survive if they're spending more than 15 minutes with a patient. Yet the patient might be a patient with 5 or 6 problems: diabetes, high blood pressure, hypertension. They might have marital issues with their spouse. And some of these elderly patients, it takes 15 minutes for them to dress and undress. And you might have a limited number of examining rooms. So it's not financially possible for the GP to deal with counseling to the extent, education to the extent that they would like. So these facilitated user networks are co-produced by the members, and they're highly efficient. An example of this might be Weight Watchers or Alcoholics Anonymous or the Crohn's and Colitis Foundation. And I think that they're a very valuable adjunct, facilitated user networks. And you notice that the initials stand for fund, so it's easy to remember. So what about the history of our conferences? We've had 2 or 3 conferences at the Johns Hopkins by Washington Conference Center. It's a great facility. It's set up perfectly for conferences. And many of our conferences run the whole gamut of our curriculum. So that's basically quality and safety, compliance, ethics and health law, business decision-making, human resources, health tech, including artificial intelligence, the Internet of Things, blockchain. And again, many of our conferences run the whole range of our curriculum. This is another conference we had in Philadelphia, your Rittenhouse Square. And this is our Northeast Corridor Conference. And the reason we chose this area is because there are 5 medical schools in a 19-block area. This is a picture of a conference. This gentleman in the middle is Christopher Shute. He's he is the #1 medical informaticist in the world. And the reason he's a Bloomberg professor at Johns Hopkins, and the reason we were able to get him to speak was that Trish Davidson was the dean of nursing at Johns Hopkins, and she made him an offer he couldn't refuse. Anyway, he gave 2 speeches, 2 talks. One was on the curation of medical informatics and ICD-10, and he was on the ISO committee developing ICD-11. And he also gave a dinner speech, which we'll get to in a minute. This, by the way, is Francisco Ward, in whose barn we're having our October 29th event. We had a conference in Washington, D.C. on the integrative approach to the evaluation and management of pain. And I know that integrative medicine is near and dear to Charles's heart and that of some of our fellows. Here you see Carl Middleton giving a talk. Carl Middleton's our Senior Vice President of Ethics. He's been an ethicist and theologian for 40 years with Catholic Health Initiatives. And some of you will know he not only has a doctor of ministry, but he has a doctorate in naturopathy, which I know is, I think, something that Jeff Cantor and Charles Froman are interested in. We had another great conference at Georgetown, a beautiful place to have a conference. Now, this relates very strongly to what Jeff Cantor was talking about. Right now, we have rivalry among existing competitors, and these are essentially the BUCAs, Blue Cross United, Cigna, Aetna, and Humana. And the winner is partially determined by the bargaining power of the buyers, such as employers, unions, these are the sponsors, and the bargaining power of the suppliers is essentially our physicians and hospitals. Then there's the threat of new entrants, which would be another insurance company, but we all know that there's so much regulation that the barrier to entry of new competitors is extremely high. But we also have the threat of substitute products or services. And again, this is from Porter's 5 Forces, which is a very famous construct taught in many business schools. So in this case, the threat of a substitute product or service would be the sharing plans, such as the Zions of the world. Again, something near and dear to Charles's heart.
As usual, another great guest, but a quick diversion. You'll notice that our full name is the Marketplace for Health, Wealth, and Freedom. Well, let's talk about your health for a moment. If you'd like to escape from the stranglehold of insurance and be able to see alternative doctors or go across state lines for care, then you definitely need to take a look at patientempowerment.mpb.health and see if that's the fix you've been looking for. Now, let's get back to the show.
Now, it's very interesting because Clayton Christensen, again, who was a very famous healthcare planner, talked about the difference between disruptive innovation and sustaining innovation. And what he says is that sustaining innovation sustains the existing trajectory of performance, and it results in fancier products that can be sold for higher profit to the best meaning the best able to pay customer. And again, these are the BUCAs, and these products include more bells and whistles than most customers need. And I think, this sounds familiar because we know with this so-called ACA, many of these policies include things that nobody uses or wants. And the disruptive innovation, the product is not as fancy and therefore is not as desirable to existing customers. And we've talked about the difficulty that employers have of selling direct contracting, for instance, to their employees because they're afraid of losing them. So it doesn't appeal to as many customers in the existing market. But the disruptive innovation, again, you could talk about these sharing plans. They're simpler, cheaper, and affordable. So they bring previously ignored customers into the market. So customers that couldn't afford insurance before may be able to afford one of these sharing plans. And again, the disruptive innovation is less profitable to the incumbents, to the BUCAs. It's introduced by the new entrants like the Zions. And the trajectory continues to improve, however, it starts appealing to even the best customers. I put best in quotation marks because that, in this context, means the customer is most able to pay. So the dominant incumbents, the BUCAs, lose their competitive advantage. So I think that Clayton Christensen, unfortunately, who died within the last year or two, really seems prescient. And he's really talking to disruption in the healthcare delivery space. So this is, we're having a reception to talk about these things, October 29th. The speakers are going to be Jawad Ashad, Kelly Webb, Kristen Dickerson, Carl Schuessler, and Charles Froman. And I thought I would let Charles talk about these individuals and this conference if you're there, Charles.
I am, and if I'm coming through okay, I'll just keep speaking.
Yes.
Fine.
Seems to be an echo somewhere, Jeff. Does someone want to mute other folks while I speak, maybe? So we heard Dr. Levien speak about some of the trustee events over the years, and this is a big event with not many people in the 30s to 40s, just because of the capacity of the nice barn at which it's taking place outside Baltimore. But what's special about it is it's our coming out party after being hibernating for the past year during the COVID hysteria. And a lot of folks are excited to drive up outside Baltimore. Some are flying in from outside the country. And we have a theme. It is the main way most disruption is happening in health payment. That's around direct payment. And that's something that brokers are doing for the bigger employers, directly contracting with local hospitals, DPCs, which are subscription primary care, pharmacists, ambulatory surgical centers, cash imaging, with the idea that if you use self-funding, get out from under the thumb of these BUCAs that David mentioned, the insurance companies, you could save money and actually give employees less liability in terms of out of pocket. You can really shrink those deductibles, which hurt so many families and which discourage care, delay care. And then where Jeff Cantor and I come in on that area for the smaller employers and individuals is the sharing that David has been mentioning. One of the unintended consequences of Obamacare is the unaffordability of those insurance plans to upper middle class voters, like realtors, people on their own, paying $1,000 for healthcare. A new market around mutual aids, like a credit union, is called medical cost sharing, has exploded, offering protection for up to 1 million people now nationwide. And it's really a great unexpected result of Obamacare is that now insurance companies are facing competition from the sharing companies, which people increasingly are liking better. We're getting that sophisticated customer that David showed in his slide. And we'll have Jawad Arshad, who is now marketing this app to facilitate the cash appointments that we're promoting through these innovations, competition around price sensitivity. Kelly Webb will be there, who is really bringing concierge to a new level to help workers find and experience the best surgeons for those specialty type of acute visits. And Kristen Dickerson will be there. She is offering not just cash imaging, but interpretation of the imaging, which apparently is a difficult thing to master. And then Carl Schuessler is one of the so-called Rosetta brokers helping structure these direct contracting plans for the larger self-funded employers. So lots of employers will be there, lots of doctors. Doctors are looking to get more cash appointments and get out from under the thumb of being employees in hospitals or just relying on reimbursement from insurance companies. So we are really at the tip of the spear of this cash market and direct contracting. which can free providers and doctors to spend more time being a doctor, which they love, and can give employees a better, more affordable plan, which gets them from out of under the networks that insurance companies use, that handcuff choices networks, lowball reimbursement, and that chases away the best doctors and hospitals from these networks. So that's the events a week from Friday, Dr. Levien. Is that pretty accurate description of the event? You're muted, David.
Yes, Charles, that's a great description as usual, and I think we're going to have a lot of fun. We've got great food and beer and wine. It's going to be a good time. We have a lot of really visionary people there. I think the networking is going to be is really going to be fantastic. And I would say that Kelly and Suzanne Webb for e-surgeries were really nice. They've sponsored this along with Jawad and Kristen Dickerson from Green Imaging. So those three companies have really sponsored the food and beverage. So we appreciate it.
So what about your wealth? If your money could actually talk to you, would you listen to it? Well, with the DNA Network Academy, your money actually can talk to you, and it's going to tell you just what it told this client. This family had over 24 debts, mortgages, car loans, the works. They were on track to take 20 years to pay it all off, and instead did it in 8.5. Plus, they did it without refinancing, making more money, or even changing their lifestyle. So find out for yourself with a free analysis that is completely confidential. No personal information, no social security numbers, no credit checks, none of that nonsense. But what is exciting is that the outcome of that report you receive is a guaranteed outcome for you. To get that report, head on over to bit.ly/debt to wealth. You will arrive at this simple form. Fill it in as simple as lender number 1 and credit card number 2. What really matters is the accuracy of your numbers. You'll be able to see that if instead of 20 years or whatever your number is, that you may actually be out of debt and on your way to wealth in as little as 6.3 years like this client. I was going to ask, obviously there's going to be some networking, and obviously you're going to get some exposure for these various entities that are engaged in these different things. Are you guys trying to get to some resolutions on some specific problems that you're working on solutions collectively, or is it more just a networking and see what synergies develop type of an event?
Well, I think that the answer is both. In my experience, the most valuable part of this is we have some really good minds who are going to be able to collaborate, and much of the work happens after the conference. People will know how to contact each other, and I think lots of good things happen. I mean, clearly after our event in Asilomar, near Pebble Beach, there are people now who are really doing business big time together, and a lot of exciting things have come of it. And by the way, the American College of Healthcare Trustees has some great things coming up. We have a Healthcare Leader of the Year award that's coming out soon. We have a press release that will come out soon about us promoting the Medical Value Index, which evaluates all the hospitals in the country for quality and price. And the AMAC, which is a 2 million person group, the Association of Mature American Citizens, have 2 million people. They have purchased this service for their 2 million members. They're a conservative alternative to AARP. So that's very exciting. We're sponsoring a hackathon where we put together data scientists and clinicians to deploy artificial intelligence to solve real world health problems. And that's going to be very exciting. We've just signed an agreement. We're doing site security for hospitals and clinics, de-escalation, active shooter drills, and we're promoting security cameras and intrusion alarms, et cetera, that use artificial intelligence to identify threats. We have so many really exciting things happen. We have a new gamification app so that people can learn in 5 and 10 minute aliquots on their cell phone while they're waiting in line in the bakery or in between meetings. And anybody who has an interest in authoring these games, we can help you do that. So, and we're also thinking that we may put together a governance and leadership textbook. And so again, lots of exciting things.
Quite diverse. Charles, I see your hand is up.
It is. And as someone who has helped Dr. Levien grow the American College of Healthcare Trustees over the past year in various ways, what is your vision, Dr. Levien, for the better health market that has to arise, not just out of the COVID hysteria, but out of the cartel's top-heavy problems about which everyone has known for years before COVID? Obviously, your three-part goal for the trustees, better ethics, decision-making, leadership, and you may correct me on the mission. I mean, those are three good missions to help this 1/7 of the economy, healthcare, upgrade in so many ways. Is it the direct contracting that's going to raise the ethics and the quality of the offerings? What are the dynamics that you see are going to give America and hopefully the world better healthcare?
Right. Well, I've heard for decades now that that healthcare is 17% of the GNP and it's unsustainable and this and that. But what people are really saying is that it's 17% of the economy that they don't control, and that annoys them. So if the car industry said that they were responsible for 70% of the gross national product, everybody would say, well, that's great. You're doing a great service. But what's more important than healthcare? You have your health and your relationships and your finances is really nothing much more important. But the problem is that so much of it is wasted. Something like 80% of the people in healthcare never see a patient. So we need to get the waste out of the system. We need to deploy our resources towards things that work and things that improve the patient experience. And using technology, I think, is going to be very important. Blockchain, artificial intelligence, the Internet of Things, data science. I think that data scientists and clinicians need to become best friends because data scientists, understand things like artificial intelligence, but they often don't understand the problem that needs to be solved, and they sometimes solve irrelevant problems. And the clinician needs to trust the data scientist and be able to deploy machine learning, deep neural networks for the benefit of their patients. But it's hard to get clinicians to trust deep neural networks when they're such a black box. They're not. It's very difficult to understand how the input into a deep neural network results in the output. So very important to to be able to explain to doctors. They might not understand every bit of how the sausage is made, because even the data scientists can't necessarily say how the output is derived from the input. But it's important to be able to explain the process in generalities. And that's part of our mission, to put people together, to have them work together so that they trust each other. You know, when Eisenhower had his heart attack, there wasn't much that could be done for him. You know, the only thing that could really be done is give him some supplemental oxygen, give him some morphine, rotating tourniquets. Now you're liable to have a percutaneous intervention. You're going to have expensive medications, but your heart muscle is likely to be preserved so that you don't wind up with heart failure. So there's a good reason why healthcare is so expensive. We just need to make sure that the things that we do are things that really provide value.
Dina? I saw your hand up. You have to unmute yourself, though.
Oh, you calling on me?
There you go. Yes.
Hello. Hi, Dr. Levien. We talked a while ago. Remember me?
Yes, how are you?
I'm very good. How are you?
Good, thank you.
Yeah, I'm enjoying this. I'm really loving a couple of your slides. I was going to reach out to you afterwards, but this disruptive versus sustaining innovation. I know I'm in a real niche here, and it's gotten even smaller since the pandemic because both medical and tourism has been totally shut down. But I wonder if there's well, I'm sure you'll probably say yes. It looks like there's probably room in your organization for those of us in the international healthcare arena as well, correct?
Yes, absolutely.
Yeah, because I just think that there's lots of opportunity there, and I was just giving a webinar on medical tourism to a group of patient advocates here in Arizona, and was discussing the very real possibility of medical tourism really becoming an option now, and the need for it to be a safe one and an ethical one. You probably saw that patient in Colorado a while ago, last week or so, that was denied her transplant because she wouldn't have the vaccine.
Yeah, that's ridiculous. Obviously.
Yes. So I feel that it might really be an option if these kind of restrictions, continue here. So definitely would like to speak to you afterwards, sometime next week or whatever. And
absolutely, it would be my pleasure.
Yeah, I'd love to make it to the meeting next week, but kind of short notice now.
Yeah, no, it would be a pleasure. Yeah, medical tourism, I think, is good for a number of reasons. Number one, competition is good.
Oh, absolutely, yeah.
And many of these places like Singapore, India, where they have medical tourism, people can go, they can get their surgery at a much lower cost, stay in a 5-star hotel.
Mm-hmm.
And there are even labor unions that encourage and pay for this. And you'd think that a labor union would be against it because it's, to a certain extent, disenfranchising American workers. But they are paying for it because it can be so much less expensive. The other thing that it points out that is that in America, and again, I think a lot of what we do is wonderful, but a lot of what we do is spinning of the wheels. So in 1979, I was a surgeon in England for a year in the National Health Service after I finished my training here. And I did more surgery in a year than the average surgeon would do in 5 years here. And I had a list that started at 2 p.m. on a Friday. And I might do a colon, 2 or 3 gallbladders, and a couple of other small cases. And then when I would get out of the operating room, my houseman would say, Mr. Levien, an appendix and a torsion of the testicle just came in. The volume was tremendous.
Yeah.
We didn't spin our wheels. We didn't clean the room in between, which doesn't really need to be done. When you didn't go and have a cup of coffee in between, you washed your hands because the next patient was put to sleep in the anteroom, and they brought them in on a canvas stretcher with slats, put it on the OR table and removed the slats. And you didn't write orders in between or dictate a note. The patient just went back to the room, and the ward sister took care of them. And the ward sisters were very smart, highly respected in the community. You'd come on the ward the next morning, and they'd say, Mr. Levien, this is your colon from yesterday. I started them on clear liquids. I took out the catheter. I did this, did that.
Yeah.
And, they did most of the routine things. And when the ward sister called you, you knew that there was a problem because they could take care of most things.
Yes. Yeah, absolutely.
Very good. Dr. Merritt, I know you wanted to make a comment. You have to unmute there.
Mute, yeah. What jogged my thought was the comment about medical tourism, which is fine for big things, but I think we need to realize there's a big underground rapid evolution happening in medicine, right underneath maybe what you're seeing if you're in the hospital setting. And that is that people are afraid to go to hospitals. They're afraid to go and be ignored. Like I know of a retired physician who had classic small bowel obstruction symptoms and was, because he had a positive COVID test, he was put on a COVID ward, ignored, and died without any workup. And that's just one of so many cases. I mean, you may have seen the guy running out of the hospital, who I think also was a physician, by the way, that was trying to get help for his bedmate, the guy in the next bed. And he's running out saying they're killing people, they're just drugging them. So there's a lot of fear going to the hospitals. And then there are doctors, and I'm one of them, people that are trying to treat people outside of the hospital to avoid them going to the hospital. And it's been made incredibly difficult by simple things like not being able to get outpatient oxygen to people. So what's happening is one of the worst ones I heard, by the way, and I know this to be true, is that someone had to get vaccinated because they just gave birth and now they couldn't take the baby home. They would not release the baby to the mother unless she agreed to be vaccinated. That's just horrible, unethical medicine. But in any case, what people are doing is they're looking at other alternatives. And one of the things that's coming out here is like a community, like instead of a food co-op, a medical co-op, a health pod, where we have things like a couple oxygen generators, some IV tubing, some IV setups, things, and maybe a part-time nurse who can't work at the hospital anymore because she's not vaccinated, a retired physician. And you'll have local community cash pay, low cost, everybody buys in like a food co-op. That's on the table right now all over the country. So I think there's kind of two levels of things happening. One is the hospitals, when we get done with all this, are going not to look like they do today because people simply have lost trust in them. And I think that there's going to need to be multiple levels of this care, and most of it's going to be cash. The stuff I'm talking about, it's not going to be running through medical clinics like it is now. I don't know. I think that's what's going to happen because there's a lot of unrest out here about this.
Yeah, well, there's no question. A lot of bizarre things are happening in the hospitals. They're incentivized to call cases COVID cases that aren't. I'm not sure if you're familiar with the 1135 waiver, but hospitals get the dispensations from various quality measures that are onerous to maintain if they have 50, if they say that they have 50 COVID cases. So they're incentivized to sign cases out of COVID that have nothing to do with COVID. Also, reimbursements are increased. So, there's no question that you have to be careful what type of behavior you incentivize, because you're liable to get it. So I agree with you. And, the issue with hospitals and their bizarre and absurd COVID restrictions are that in many cases, unfortunately, the public demands it. The public has been driven into a frenzy by, some of these nuts and flakes on the news. And so they demand that hospitals do this. And, the hospital CEO is doing it to cover their ass. But you're right, it's terrible. And it really interferes profoundly with patient care. So anyway, surgeries, for instance, more and more are being done on an ambulatory basis. And in fact, we're in negotiations still to buy several ambulatory surgery centers and manage them. I just heard today from a potential funder. But we also have with us a real expert. Kelly and Suzanne Webb run e-surgeries, and perhaps they'd like to comment.
I was just going to suggest that it was a good setup on your prior discussion. So Kelly, if you would, please intercede.
Oh, thank you. Can you hear me okay?
Excellent.
Sure.
Yeah, I just wanted to comment and say that we really appreciate all our board certified surgeons out there and doctors that are in this fight to actually provide better health care to patients. You're still focused on the patients and taking good care of them with common sense. There's in this dramatic situation of times, we have to keep cool heads and focus on things. But I think one of the things that we're trying to do and are looking at that works really well is we're seeing a lot of industry change where they're looking for board certified surgeons to literally take their surgeries to where it matches the patient's needs. For example, we like to redirect our patients from we're incentivizing the benefit plan to literally waive the copay, waive the deductible. The employer agrees to that, to then redirect the patient to a ambulatory surgery center when it's applicable for the patient. All of this goes along with the doctor's recommendations. But literally, if we can get them into an ambulatory surgery center that doesn't have this high price point, this high cost point, and they're still getting board certified care, they're getting a registered nurse, and obviously their surgeries are for those elective surgeries. Now, what we've encountered is that because we have a very concierge hands-on approach where we're dealing with the doctor directly, we're pre-negotiating the case, and we're talking with them about the needs of the patient, we will stick with that patient, follow them through to the hospital if the doctor says, hey, this lady with this hip, she can't be done in an ambulatory surgery center. Her modalities are too high. She has all these other problems. I've got to have 2 or 3 other surgeons in on this deal, and we're going to set it up in that manner. And the reality is we'll go with the patient to the doctor and pre-negotiate the case. And what's happening is we're able to negotiate with the hospital, the anesthesiologist, and the surgeon ahead of time, set all that up, and functionally put the functions he needs to get his work done and bring it in at a decent cost point that the employer's going, okay, I'm not being overcharged for this. I'll agree to this and we'll just get it taken care of. And so the plan's working and works well, but we obviously need more volumes too and more involvement nationwide. So it's not a solution for everything, and we can't replace the higher modalities. But if you look at what the employer groups are going through, a lot of them are paying so high for some of these premiums, they keep having to change their plans. The plan that used to be companies that would offer a 90-10 split on what was covered have now dropped those to 50-50, where the patient's having to pick up so much. And at any rate, there's modality changes going on. I just attended a broker conference talking about healthcare, and it really looks like the whole industry is looking for solutions of more direct contracts with great doctors, great surgeons at affordable prices. And if we can provide that as a medium that's out there we have clients and customers that are interested in it. And so it's a balance of everything, but the reality is our focus too is to not sacrifice that quality for that patient's experience. And the person that brings that quality are these board certified surgeons like yourselves. Bringing that straight home is the only way to really get it done, because anything else, and we have competition out there that just wants to put the case at the lowest rate possible. That's not our model. We're a value-based model trying to bring in really fair rates for the surgeons and the ambulatory surgery center, the anesthesiologists, and we get them signed off and agreed to. So, but like I said, it's as Dr. Levin was pointing out earlier, there's obviously still big elephants in the room like United Healthcare and Blue Cross and Cigna and Aetna that are driving this, but a lot of them are looking at what we're doing and realizing this is where the public really wants to be, and they're trying to drive them there. So I don't know. I hope this makes some valid points for you that kind of helps understand that I see a big change coming too, that the public themselves are crying for more help in 4 or 5 areas of focus, but nobody wants to sacrifice the quality either. So as far as I see it, I think the surgeons have a great product that they just continue to do what they're doing and focus on their modalities and taking great care of the patient. And anybody that's involved with us, we try to make sure we're taking care of those surgeons along the way, that they're getting paid more literally for cases than what United Healthcare would pay them or Blue Cross. We know that we can, in our bundled claims, we increase the amount of money to those surgeons. And so because it's bundled claims, that literally is an opening that helps to process the whole claim a little cheaper, because it's one claim that the third-party administrator has to look at. But literally, with our background in billing nationwide, we understand about where the fair rates are. And we're not talking usual customer, we're talking about a fair rate for a surgery. And so our cases are not we're trying to be in that sweet spot of that balance where it's not the cheapest case out there. It's not the most expensive either, but the surgeon walks away going, hey, I made decent money on this. I felt good about providing this care, and I took care of the patient and got paid for it. And I didn't lose money on that case. I mean, we've seen many things in our history of doing billing for surgeons and doctors and providers that made us sick to our stomachs, because the surgeons were eating way too much of the cost of some of these things. And we're glad to see it starting to turn around where they should be paid for what they're doing.
To enjoy this and all past shows, head over to our website at your-mp.com. When you get there, look for the Home tab. When you hover over it, select Webinars from the drop-down. And when you get there, then scroll down near the bottom to find the 4 platforms where we archive all the shows. Here they are on Brighteon. And also remember to use our Continuing the Conversation to connect with all of our great guests. Very good. You guys have really been doing a lot for sure. What were you going to say, David?
Oh, no, I've had the opportunity to speak with Kelly and Suzanne of eSurgeries offline, and I believe they get it. I think they understand exactly how to bring value to both patients and payers, or not payers, sponsors. I think.
Charles, we got time for you to slip in the last question.
So Dr. Levien, how would you categorize most of the trustees members, and what kind of medical professionals have you been attracting as a fellow recently? And then after the October event next week, where do you see the trustees going over the next year?
Sure. So we have a very eclectic membership, and our members are called fellows, and we have hospital board members, medical practice board members. We have hospital executives. We have physicians, some in private practice, many in private practice. We have nurses. We have healthcare attorneys. We have quality and safety experts, human resources people. So a very eclectic membership. And we have people who are essentially represent the community. They're not healthcare professionals, but really consumer representatives. So really anybody of good character can become a fellow. And then we have opportunities to earn belts in various aspects of our curriculum and to earn various designations such as fellow with special merit, fellow with distinction. But the main thing, and we have a number of vendors who sell to the healthcare space. So, and by the way, Linda, I believe you're coming to, Linda's raised her hand, and I think we should give her an opportunity.
I would say we can let her slip in here real quick. Go ahead, Linda.
Yes, Dr. Levien, I'm looking forward to meet you next week. Before, I'm going to send you a detailed bio for me, what I did in my life, for you to see how I can help your organization. And it's very important because I have a very special background. European and American, Johns Hopkins, and epidemiology and immunology, all of this.
Yes,
Okay.
well, yeah, absolutely. I saw that you'd registered, and I saw that you have 2 PhDs, if I'm not mistaken.
Yes, many things.
So we want your brain.
What you said?
I said we want your brain.
I would like to give you my brain and my life to you, everything. I tell you.
Yes, figuratively speaking, we want your brain. So
Okay, absolutely.
we look forward to meeting you.
Very good. Well,
Stay
that
with me.
was,
Thank you.
that was a very nice session today. So David, I want to definitely thank you much for being here today.
Well, thank you, Jeff, as always. It's always great to spend time with you and the other members of this group.
Excellent, excellent.